Hey everyone, welcome to today's Explainer, which is a highly requested deep dive into myopathies. If you're currently grinding through prep for your NEAT SS or NESS neurology boards, or, if you're just a clinician who absolutely loves geeking out on neuromuscular medicine, you are 100% in the right place. We're going to systematically deconstruct the clinical, electrodiagnostic, and molecular genetic landscapes of these really complex disorders. Basically, we're taking those dense, heavy textbook paragraphs and translating them into clear, highly testable concepts you can actually use. Let's get into it. Here is our roadmap for today. First, the clinical and EDX approach. Second, dystrophinopathies and LGMD classifications. Third, Emery-Dreifuss, FSHD, and DM. Fourth, metabolic and mitochondrial myopathies. And finally, number 5, channelopathies and toxic myopathies.
All right, let's kick things off with Section 1, Clinical and EDX Approach, the Diagnostic Foundation.
Okay, so when you're staring down a really complex clinical vignette, your absolute first step has to recognizing these 4 core phenotypic patterns: proximal, distal, episodic, and ocular. If the board question gives you proximal limb girdle weakness, your brain should immediately jump to structural dystrophies or metabolic storage diseases. Distal weakness, on the other hand, should pivot your thinking towards specific distal myopathies or maybe even a masquerading neuropathy. Now, episodic weakness or myoglobinuria that's tied to exercise, that literally screams metabolic or channelopathy. And isolated eye muscle weakness, ptosis with or without ophthalmoprisis, that should definitely trigger alarms for mitochondrial defects or neuromuscular junction disorders.
Before we move on to specific diseases, we literally have to clear up a massive point of confusion, and that's the difference between a cramp and a contracture. This is so crucial. A contracture features electrical silence on your EMG, and that points directly to a glycolytic defect rather than just a simple spasm. The muscle literally runs out of ATP, and it just cannot detach those actin-myosin cross-bridges. It becomes hard as a rock, but electrically, it's completely silent. Keep that in your back pocket.
Moving right along to Section 2, Dystrophinopathies and LGMD classifications, the structural defects.
Take a second to really map out exactly where these proteins live anatomically. Think about the sarcolemma up top. Dystrophin is essentially this massive shock absorber that connects the actin cytoskeleton to the extracellular matrix through the dystroglycan complex. When dystrophin is completely missing, you get Duchenne. When it's just truncated, you get Becker. But we got to look deeper, right? Down at the nuclear envelope, that's where proteins like amarin and lamin reside, or the sarcomere itself, where titin and myotilin sit. Knowing exactly where the mutated protein lives makes understanding the downstream pathophysiology so much easier.
Listen up, because board examiners absolutely love recent classification changes, so you really have to memorize this shift to the ENMC criteria. Historically, we used LGMD1 for dominant and LGMD2 for recessive, but the new system, it uses D for dominant and R for recessive. So the classic autosomal recessive LGMD2A now maps to LGMDR1, and that's caused by mutations in the CAPN3 gene for calpain-3. It's also super important to note how old categories are being entirely reclassified based on that anatomical map we just talked about. LGMD1B is now classified under Emery-Dreifuss because it's a laminopathy, and LGMD1A is categorized as a myofibrillar myopathy type 3 because it involves myotolin. It's a real game changer for how we categorize these.
Next up is Section 3, Emery-Dreifuss, FSHD, and DM, nuclear and excitability defects.
You definitely want to nail down this high-yield distinction. Notice the early fixed contractures and the frankly life-threatening arrhythmias in EDMD and compare that to the classic scapulo-peroneal winging in FSHD. If a clinical vignette describes a young patient with rigid neck and elbow contractures, plus they have a pacemaker or a heart block, boom, you're dealing with Emery-Dreifuss, which means mutations in EMD or LMNA. On the flip side, if the patient has a transverse smile, maybe they can't whistle, and they've got asymmetric scapular winging with foot drop, that classic humeroperoneal distribution, that is absolutely facioscapulohumeral muscular dystrophy. Now, check out this rapid-fire contrast between the two types of myotonic dystrophy. You need to firmly associate DM1 with distal weakness and the DMPK gene. Picture the classic patient, hatchet facies, frontal baldness, and that hand grip myotonia, where they literally can't let go of a handshake. DM2, on the other hand, classically presents with proximal weakness. Actually, it's literally right there in the alternate name, PROM, or proximal myotonic myopathy. Both of these are autosomal dominant trinucleotide repeat expansion disorders, but their clinical distributions are essentially mirrored.
All right, let's push forward into Section 4, metabolic and mitochondrial myopathies, the energy defects.
When we talk about metabolic myopathies, I want your brain to immediately link McArdle's with the PY gene and Pompe with the GAA mutation. McArdle's disease is your classic type 5 glycogen storage disease. These patients experience really intense muscle cramps, or, more accurately, contractures, shortly after they start high-intensity exercise. Now, Pompe disease is an entirely different beast. It's a lysosomal storage disorder that causes severe proximal weakness and, in infants, massive cardiomegaly. A quick tip: Pompe is heavily tested right now because there's actually a specific FDA-approved enzyme replacement therapy available for it.
So how do we actually test for these metabolic blocks in the clinic?
Well, we use the ischemic forearm exercise test. And here's the absolutely crucial takeaway for your EDX workup. A reduced lactic acid rise post-exercise flags a glycolytic defect. Why? Because the muscle just cannot break down glycogen into lactate. That is the absolute hallmark of McArdle disease. But if you see a normal lactate rise, that tells you the glycolytic pathway is completely intact. That points your diagnostic compass straight toward a lipid disorder, like CPT2 deficiency, especially if the patient is dealing with exercise-induced myoglobinuria after prolonged fasting or sustained low-intensity exercise.
Let's move from fuel to the powerhouses themselves, the mitochondria. You absolutely must recognize the classic triads for mitochondrial syndromes. Kearns-Sayers is strictly defined by onset before age 20, chronic progressive external ophthalmoplegia, or CPEO, and pigmentary retinopathy. A massive flashing red flag for KSS is complete heart block. These patients frequently die from cardiac arrest if they aren't paced. MELAS, conversely, presents with early stroke-like episodes. We're talking hemiplesis or cortical blindness that totally ignores standard vascular territories. And isolated PPO is exactly what it sounds like. But notice this: they rarely complain of true diplopia because those ocular muscles weaken symmetrically.
And finally, we arrive at Section 5, channelopathies and toxic myopathies, excitability and acquired defects. Okay, when you're dealing with potassium channelopathies, the standout board question, without a doubt, is Anderson-Tawil syndrome. It's characterized by the KER 2.1 mutation. What makes this one so recognizable in a vignette are the dysmorphic features. Think short stature, low-set ears, micrognathia. And those are paired with highly dangerous cardiac arrhythmias, like a prolonged QT or bidirectional ventricular tachycardia. Contrast this with your periodic paralysis. Hyperkalemic is actually a sodium channel mutation, while hypokalemic is often triggered by heavy carbohydrate meals or just resting after intense exercise, which drives potassium into the cells and causes profound weakness.
Switching gears to chloride channel defects, which give us myotonia congenita, these patients literally look like bodybuilders because of this prominent muscle hypertrophy. Both Thompson and Becker are caused by CLCN1 mutations, but you have to notice the clinical split here. Thompson is the autosomal dominant form. It's generally milder and patients have normal muscle strength. Becker is the recessive, more severe variant, and it can actually feature transient muscle weakness. But in both cases, the hallmark is myotonia that ironically gets better with continued activity. We call this phenomenon the warm-up effect.
I'm going to leave you with this little clinical vignette to test out your new pattern recognition skills. So a contracture with a silent EMG strongly suggests a metabolic issue. But wait, consider that lactic acid rise carefully. If it's normal, where does the defect truly lie? Use what we just talked about to secure your diagnosis. Thank you so much for joining me for this explainer. I hope it was helpful, and keep studying hard.